Hello everyone, I am Dr. Akif Baig, consultant cardiologist. Today I'll be talking about heart failure guidelines. So definition of heart failure. A heart failure is not a single pathological diagnosis, but a clinical syndrome consisting of cardinal symptoms like breathlessness, ankle swelling, and fatigue that may be accompanied by signs like elevated jugular venous pressures, pulmonary crackles, and peripheral edema. So heart failure symptomatology is basically assessed based on New York Heart Association classification, which is classified breathlessness into four classes: class 1, 2, 3, and 4. Class 1, there is no limitation of physical activity. Class 2, slight limitation of physical activity. Class 3 is marked limitation of physical activity. And class 4 is severe limitation, that is symptoms present even at rest. So stages of heart failure based on ACC and American Heart Association. Stage A is at risk for heart failure, where the patient will have only a risk of heart failure, but the heart is structurally normal. So patient have risk factors of heart failure include hypertension, diabetes, obesity, and exposure to any cardiotoxic agents. Stage B is pre-heart failure, where the patient doesn't have any signs and symptoms of heart failure, but there are structural heart diseases, like there is evidence of increased filling pressure or evidence of increased natriuretic peptide levels or elevated troponin levels. So there are evidence of heart disease, but there is no symptoms. So that is stage B. Stage C is where patient have a symptoms of heart failure, and stage D is advanced heart failure, that is marked heart failure that interfere with daily life activities even after optimized guideline-directed medical therapy. So heart failure is basically classified into four types, that is heart failure with reduced ejection fraction and mildly reduced ejection fraction, preserved ejection fraction, and improved ejection fraction. So heart failure with reduced ejection fraction is defined as patient, all these classifications, patient should have a symptoms or signs with ejection. If there is ejection fraction of less than 40% assessed by 2D echocardiography, then it is called reduced ejection fraction. Mildly reduced ejection fraction is ejection fraction of 45 to 49%, and preserved ejection fraction, where ejection fraction is more than 50%. So there is one more entity called as heart failure with improved ejection fraction, where a patient who was initially had reduced ejection fraction, that is EF of less than 40%, after guideline therapy, after medication therapy, the ejection fraction is improved to more than 40%. So heart failure with reduced ejection fraction was traditionally called as systolic heart failure, and heart failure with preserved ejection fraction was traditionally called as diastolic heart failure. So any patient with a heart failure, what is the diagnostic algorithm? So if you're suspecting any patient who is may have a heart failure, there is symptoms and signs, abnormal ECG or risk factors if they are present for heart failure, you need to first do NT-proBNP or BNP levels. So if this NT-proBNP or BNP is elevated, then you do is echocardiography to define. So NT-proBNP elevated, it means that patient have heart failure. If there is yes, then you do echocardiography just to label patient as either reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction. Suppose NT-proBNP is normal, or there is no echocardiography has no abnormal findings, then you should suspect that this heart failure is very unlikely, and you should consider for other diagnosis. So management of patients with heart failure with reduced ejection fraction, that is AC heart failure with reduced ejection should receive this. This is a class 1 recommendation. That is, this all drugs should be compulsorily there in patients of heart failure with reduced ejection fraction, that is EF of less than 40%. So AC inhibitors or ARNIs, that is angiotensin receptor neprilysin inhibitors, beta blocker, mineral receptor antagonist, dapagliflozin or empagliflozin, that are SGLT2 inhibitors, and loop diuretics for fluid retention. So suppose the patient has class 1, and if the ejection fraction is less than 35%, and in ECG you see QRS of less than 130 milliseconds, the patient is actually indicated for ICD, that is defibrillator. That is, if there is ischemia is involved, and there is persistent EF less than 35%, then it is class 1 recommendation, and class 2A for non-ischemic one. We will get to this in detail. Pharmacological treatments to be considered in patients with New York Heart Association class 2 to 3 in heart failure with reduced ejection fraction. So in all patients of EF of less than 40%, in ACE inhibitor, beta blocker, mineral receptor antagonist, dapagliflozin or empagliflozin, and ARNI, a sacubitril or valsartan. These are our class 1 recommendations. So ARNI should not be administered concomitantly with AC inhibitors or within 36 hours of the last dose of an AC inhibitor. So that means that suppose a patient is already using a AC inhibitors in the form of either enalapril or ramipril or anything. So if you want to start them on ARNI, that is sacubitril valsartan, there should be minimum waiting period of 36 hours from the last dose. And ARNI should not be administered to patient with any history of angioedema. Also, AC inhibitors should not be administered in any patient with history of angioedema. So in overall management of heart failure with reduced ejection fraction, these are all mortality reducing drugs, that is ACE or ARNI, beta blocker, mineral receptor antagonist, and SGLT2 inhibitors. Other drugs recommended or to be considered in selected patient with heart failure with reduced ejection fraction is loop diuretics. Diuretics should be given in any patient with central symptoms to relieve it from the congestion. So if a patient have a congestive symptoms of breathlessness, pulmonary edema, or crackles are present, you should start patient on loop diuretics. An ARB is recommended, that is angiotensin receptor blocker, is recommended to reduce the risk of heart failure hospitalization and cardiovascular death in symptomatic patients unable to tolerate an ACE or ARB. So first, you should always prefer AC inhibitor or ARNI. If the patient is not able to tolerate this due to cough or angioedema, then only you should go for angiotensin receptor blocker. Funny channel inhibitor, that is evaporating, should be considered in any patient with a EF of less than 35%, is in sinus rhythm and having a resting heart rate of more than 70 beats per minute. New drugs like soluble guanylate cyclase stimulator, that is vericiguat, which increases the contraction of the heart. Vericiguat is recommended as class 2B therapy. Hydralazine and isosorbate dinitrate, these are vasodilators. It should be considered in black patients, that is in Indian African patients, where if a patient have ejection fraction less than 35%, or if the ejection fraction is less than 45%, along with the patient have a features of dilated left ventricle, it is a class 2 recommendation. Digoxin may be considered in patient with symptomatic heart failure with reduced ejection fraction in sinus rhythm, despite treatment with an AC inhibitor, a beta blocker, and a mineral receptor antagonist. So only then only it has to be considered, because digoxin have a lot of side effects. So better it has to be try to avoid it as much as possible. So additional therapies which is involved is evaporating, vericiguat, digoxin, polyunsaturated fatty acids are also recommended as class 2B therapy, and potassium binders may be used in patients with hyperkalemia. So recently reported advances, that is new drugs which are is in trials with reduced ejection fraction, is soluble guanylate cyclase stimulator. It has been seen in the Victoria study that it was shown to be very much useful in acute decompensated heart failure. There was no reduction, however, there was no reduction in either all-cause or CV mortality. So it has led to decrease in hospitalization with heart failure, but overall mortality, there is not much benefit seen with this drug. So vericiguat, it is a class 2B indication, that is, may be used in patients with heart failure. Other drug is cardiac myosin activator, which is omecamtiv, which is a myosin activator. It leads to increase in actin-myosin interaction and causes more contraction. It was also studied in Galactic HF study. The primary endpoint was first heart failure event or CV death. There was no significant reduction in cardiovascular mortality. So even this drug was found to have no cardiovascular mortality. So this drug is not licensed for use in heart failure now. So recommendations for implantable cardioverter defibrillator in patients with heart failure. So any patient who has recovered from a sudden death, and it has to be a class 1 indication in this patient to prevent it from secondary prevention, unless if it has got less than 48 hours after MI. So suppose a patient has developed ventricular arrhythmia within 48 hours of MI, then you will not put him on ICD. However, if the patient develops arrhythmias after that, and then you have to definitely put him on ICD. So ICD is also recommended in patients, symptomatic heart failure patients, that is NYHA class 2 to 3 of an ischemic etiology, that is unless they had an MI in prior 40 days. So after MI also you have to wait for a minimum of 40 days before considering patient for ICD, because generally if there is a decrease in ejection fraction, it tends to improve after revascularization. So once you have waited for 40 days, and if a patient is still having ejection fraction of less than 35%, and also a patient should be symptomatic. So if a patient is both, if patient should be both symptomatic as well as EF of less than 35%, after using of 3 months of optimal medical therapy, then also if the patient is not responding, then only it's a primary prevention. Then only if it considered for ICD therapy here. For non-ischemic etiology, it is class 2 indication. So pharmacological treatments to be considered in heart failure with mildly reduced ejection fraction. So all this therapy, that is diuretics, for any patients to relieve the symptoms of signs of congestion, you give diuretic. An AC inhibitor may be considered. ARB should be may be considered. Beta blocker, mineral receptor antagonist, and sacubitril valsartan, that is ARNI. So all these drugs were class 1 recommendation. That is, it has to be used compulsorily in heart failure with reduced ejection fraction. That is, if the EF is less than 40%, you have to definitely use it here. However, if the EF is between 40 to 50, it depends upon clinician to clinician whether to use or not. So it may be it is a class 2B recommendation here. So management of patients with heart failure with mildly reduced ejection fraction. Here the class 1 recommendation is diuretics and SGLT2 inhibitors. This has to be compulsorily given. All these three are optional. So management of patient with heart failure with preserved ejection fraction. Diuretics, if there is any symptoms of congestion or fluid retention, and SGLT2 inhibitors, that is a class 1 recommendation. And you have to treat for etiology and cardiovascular and non-severe comorbidities, that is class 1 recommendation. Heart failure with improved ejection fraction. So suppose a patient who was having an ejection fraction of less than 40% now has improved to more than 40% on guideline-directed medical therapy. So if suppose the patient is on all this therapy, that is AC, ARB, and all, and after that his ejection fraction is improved to more than 40%, then also you should continue all these drugs. So all the drugs should be continued to prevent relapse of heart failure and LV dysfunction. So we may generally tends to get that patient ejection fraction is now improved. So you should not stop treatment in this case. All this guideline directed medical therapy, that is AC inhibitors, beta blockers, mineral receptor antagonists, everything should be continued. So recommendation for the prevention of heart failure in patients with type 2 diabetes and CKD. Suppose a patient have diabetes mellitus and CKD. So for prevention of heart failure, all these patients should be definitely on SGLT2 inhibitors, and finrenone should also be used in case of this. So this is recommended as class 1 recommendation. So suppose a patient have iron deficiency, patient deficiency should be corrected, which improves heart failure symptoms. So if you want to give intravenous iron supplementation, then you have to use ferric carboxymaltose or ferric isomaltose. Acute heart failure. Acute heart failure refers to rapid or gradual onset of symptoms under signs of heart failure severe enough for the patient to seek urgent medical attention. So this means that patient will have symptoms in such a severity that he will require hospitalization for sure. Then only it is labeled as acute heart failure. So it is of 4 types clinical presentation of heart failure, that is acute decompensated heart failure, acute pulmonary edema, isolated right ventricular failure, and cardiogenic shock. So management of patient with acute decompensated heart failure. Suppose patient have presented with acute decompensated heart failure. So if first you have to see is whether the patient have any symptoms of congestions or fluid overload, whether it is there or not. Next, if the congestion is present, then you have to see whether there is hypoperfusion or not. So hypoperfusion is assessed by assessing like any perfusion, if there is decreased perfusion to any of the organs. So suppose a patient have uh, altered mental status, that is her brain is hypoperfused, he has oliguria or decreased urination, that means kidneys are hypoperfused, or if there is peripheries are cold, then it means that it is hypoperfusion. So suppose there is hypoperfusion also present, then you have to start him on loop diuretics and also consider inotropes in these patients. So hypoperfusion and congestion is relieved after using the diuretics and inotropes. If yes, then you could put them on optimal medical therapy, that is heart failure treatment. As we already know, there's all those beta blockers, SGLT2 inhibitors, ARNIs, all these things can be used for medical therapy optimization. So suppose the patient has not, after using the loop diuretics and anatropes, the symptoms are not relieved, then you have to consider vasopressors like norepinephrine, which is a class 2B recommendation. And suppose even after this using noradrenaline also there is persistent hypoperfusion or organ damage, then you should consider it for mechanical circulatory support or renal replacement therapy in this patient. So suppose there is no hypoperfusion. So suppose hypoperfusion is absent. That is, patient is maintaining BP quite well, and there is no signs of hypoperfusion. Then the class 1 recommendation is loop diuretics. You should continue in this case. So you should give drugs only for relieving the congestion. Congestion is relieved, then you should optimize the medical therapy. If it is not released, then you have to increase the diuretic doses, and or you can combine with the other diuretics. So then also, if it is not relieved, you should consider for diuretic resistance or end-stage renal failure. Then the patient should be considered for renal replacement therapy or palliative care. So management of patients with pulmonary edema. Suppose the patient is only on pulmonary edema and without any features of any congestive heart failure, then it is so only have pulmonary edema and there is no congestion. Then it is a difference between the acute decompensated heart failure and pulmonary edema. So in this case, you have to give oxygen or ventilator support if required. So next you will check is BP, blood pressure. If it is more than 110 millimeters of mercury, then you should give diuretics as well as vasodilators. So what will vasodilator do? Vasodilator will decrease the preload and afterload and thus helps in relieving this pulmonary edema. So suppose there is there is BP is not more than 110, or then you should check for if there is any signs of hypoperfusion. As I've already discussed, hypoperfusion signs of altered mental status or decreased urination. If such features are there, then you should go for loop diuretics. Give loop diuretics, and along with that, you should start on inotropes or vasopressor. So suppose congestion is relieved, then you will optimize the medical therapy. If it is not relieved, you should consider for mechanical circulatory support and renal replacement therapy. So in patients of isolated right ventricular failure, so first you should look for the cause of right ventricular failure. The most common cause is acute coronary syndrome with right ventricular involvement, or it could be acute pulmonary embolism. If yes, you should treat specifically for acute coronary syndrome and pulmonary embolism. If you do not find any of this cause, then you should optimize fluid status, and then you should check for marked congestion, whether the congestion is there or not. Whether if there is a lot of congestion is there, then you give loop diuretics. If there is no congestion, you should consider careful fluid administration. Next, check for if there is after that also diuretics also if there is optimizing fluid status. If there is persistent hypoperfusion and persistent hypotension, then you consider vasopressors or inotropes. If the signs and symptoms are relieved, then you just do a follow-up. If it is not relieved, then you should consider for right ventricular assist device under or renal replacement therapy or consider palliative therapy. Management of patients with cardiogenic shock. If any patient with cardiogenic shock, first try to rule out the cause, whether it is acute coronary syndrome or any mechanical complications like ventricular septal rupture or free wall rupture of the heart. If those are there, then you should take for emergency PCI or surgical treatments, like the specific treatment should be done. If it is not there, then you identify and treat other specific cause. You can consider oxygen and ventilatory support, inotropes, and short-term mechanical circulatory support. So management of diuretic therapy in patients with acute heart failure. So suppose a patient has came with acute heart failure. First, you should see whether the patient is already on oral loop diuretics. If already patient is using oral loop diuretics, then you should start him on IV diuretics, and the dose should be 1 to 2 times of the daily oral dose. So suppose the patient is using furosemide of 40 milligrams daily, then your IV dose should be in per day dosage of IV should be either 40 mg or 80 mg in divided doses. So suppose the patient is not on any oral loop diuretic therapy prior, then you should start him on 20 to 40 mg of IV furosemide. So after starting that, giving a dose of 20 to 40 mg of IV furosemide, you should after 2 hours you should check urinary spot sodium, and or urine output you should check after 6 hours. So after 6 hours, if the patient urine output is maintaining of 100 to 150 ml per hour, or urinary spot sodium is more than 50 to 70 milliequivalents per liter, yes, then you can repeat similar dose, that is IV every 12 hours. Every 12 hours you can give the similar dosage actually. So suppose this target is not achieved, then you have to double the dose IV until maximum IV dose you can reach. You have to reach that so that your goal should be this. So continue until complete decongestion this one, and check serum creatinine and electrolytes at least every 24 hours. If this therapy is not reached, then target is not reached, you can plan for combining diuretic therapies, that is use thiazide diuretics along with loop diuretics. Other recommendations in acute heart failure is oxygen supplementation should be given only if SpO2 levels are less than 90% or if PaO2 of less than 60. Intubation is recommended for progressive respiratory failure. Despite, suppose the patient is already on non-invasive ventilation and is still not recovering, then you should consider for intubation. And non-invasive ventilation should be considered in patient with respiratory rate of more than 25 breaths per minute with SpO2 of less than 90%. Diuretics, intravenous diuretics are recommended for all patients with acute heart failure admitted with signs and symptoms. And if you are suspecting if there is resistant edema, then you should combine it with isodiuretic. Vasodilators should be considered in patients with acute heart failure if there is SBP of more than 110 millimeters of mercury. This is a class 2B recommendation. Inotropic agents should be considered only if the patient's BP is less than 90 and there is evidence of hypoperfusion, then only you should give them on inotropic agents. Otherwise, routine administration of inotropic agents is not recommended. Vasopressor, preferably if you have to use in cardiogenic shock, the preferable drug is norepinephrine. So these are the inotropes and vasopressors which you can use in acute heart failure, that is dobutamine, dopamine, milrinone, inoximone, levosimendan, norepinephrine, and epinephrine. All patients, since all these patients will be on either ventilator support or in ICU and they are immobile, thromboembolism prophylaxis for DVT prevention should be definitely given. And recommendations for maintenance or optimization of guideline-directed medical therapy during hospitalization. So suppose patient is already on a guideline-directed medical therapy, that for heart failure he is already receiving therapy. So now he has come with acute decompensated heart failure. Pre-existing therapy should be continued and the dose should be optimized to improve outcomes unless contraindicated. In patient experiencing mild decrease of renal function, suppose his creatinine has slightly raised or patient has having asymptomatic reduction of blood pressure during heart failure hospitalization, diuresis and other guideline-directed medical therapy should not be discontinued. So we tend that BP is falling, so we start decreasing the drugs, that is ACE inhibitors or ARNIs or beta blockers. So this discontinuation should not be done and this should be continued as part of that. So in patients with heart failure with reduced ejection fraction, guideline-directed medical therapy should be initiated during hospitalization after clinical stability is achieved. So this is for those patients who has no prior history of heart failure, now has presented with heart failure with reduced ejection fraction. So first, your goal should be stabilization, and once the patient is stabilized, clinical stability, then guideline-directed medical therapy in the form of ACE inhibitors, ARNIs, beta blockers, mineral receptor antagonists should be continued. In patient in whom if there is discontinuation of guideline-directed medical therapy is necessary during hospital, suppose the BP is too low and you are not able to put them on this therapy, then it should be restarted once the patient is a little bit stabilized. So additional therapy in patient with heart failure and comorbidity, you should give IV iron replacement in patient with iron deficiency. Suppose the patient have AF, you should plan for AV nodal ablation. And patient having obstructive sleep apnea should receive CPAP therapy. And patient with heart failure and hypertension, you should treat hypertension as per the guidelines. All patients of diabetes and heart failure should receive SGLT2 inhibitors. If there is any suitable coronary anatomy and EF of less than 35%, surgical revascularization has to be done. Thank you.